During this Eha 2025 annual meeting, we had a very exciting debate about the use of DLI, donor lymphocyte infusion, versus a second allogenic stem cell transplant for those patients who are relapsing after a first allo transplant. And obviously, this is a very timely and important debate because we know very well that these days actually relapse after a first allo transplant is the first cause of failure of the transplant procedure. And this is why we need effective tools to salvage these patients. Historically, since the mid-80s, early 90s, donor lymphocyte infusion, collecting lymphocytes from the same donor and reinfusing them to the patient allowed historically in chronic myeloid leukemia to achieve complete remission again. However, in other diseases like AML, MDS, or ALL, the success was less obvious. Today, I think many colleagues continue to perform DLI, but in combination with the targeted therapies, especially when it comes to AML, because we know very well that the disease burden, the disease status before DLI is going to play a major role in the final outcome. And during this Eha 2025 annual meeting, I had the privilege to have this debate with Dr. Christoph Schmidt from Augsburg in Germany. So I had to defend DLI and he defended the role of second allo. At the end of the day, we were both, of course, in agreement because obviously we do not have a prospective phase 3 randomized trial which tested these two approaches. However, we both published together in 2018 in JAMA Oncology a very seminal, very important paper, more than 400 patients, comparing DLI to a second allo. And the key message was that actually the outcome was similar, including in those patients who were able to achieve a better disease control prior to the procedure. Obviously, the key confounding factor there is about why the investigators chose to do DLI or a second allo. And this is something that we cannot capture in a registry retrospective trial. Nevertheless, I think today, before engaging patient on a second allo procedure, and although we have to acknowledge that the outcome of a second allo has improved, especially when it comes to relapse, when it comes to non-relapse mortality, one should consider as a first option, in my opinion, whenever possible, DLI. And this should be combined again whenever possible to some disease reduction, especially with targeted therapies before the DLI. And if we are able to control the disease, actually the outcome of DLI will be much better. Obviously, the future is about, in my opinion, monitoring closely the disease with all the new technologies of MRD. And if we are able to detect relapse very early, we may be able to have earlier interventions, which obviously are going to be more effective. So you can see the debate is still open. We cannot solve this issue at this time. Nevertheless, I think now with DLI, with the possibility of performing a second allo, especially now that we're doing more and more haploidentical transplant, and in the haplo setting, you can find usually more donors in general, and the combination with the novel targeted therapies, whether FLT3 inhibitors, BCL2 inhibitors, whether IDH1, IDH2 inhibitors, and many other agents, we may be able to improve the outcome of those patients who are relapsing after a first allo transplant in case of a mild malignancy.